morning, everybody, or afternoon. I don't know what, just noon, good noon. I am Lauren Roberts, and I have the privilege of serving as the Executive Director of Forge Breast Cancer Survivor Center. Our mission at Forge is to support, empower, and improve quality of life for Alabama breast cancer patients, survivors, and their loved ones from the day of diagnosis through the rest of life. I also have had in the past the privilege of serving as the president of the Junior League of Birmingham. So this is like being at home for me. Their mission, as you see, is they are committed to promoting volunteerism, developing the potential of women, and improving the community through the effective action and leadership of trained volunteers. So in my opinion, there's no better partnership here to present this conversation, and the one last week and the one next week, of candid conversations, crucial conversations that we need to have after a cancer diagnosis, but are often hard and uncomfortable. And so our hope is to create a safe place here where you feel, whether you're present in person or online, comfortable asking questions that maybe you haven't had the nerve to ask before, but have been wondering. And to that end, I will say, and I'm going to warn the panel, I'm going to use first names today because I want it to feel like a comfortable, safe place we're not using titles. We are just people here talking about hard things. Thank you for coming. We appreciate it. And I'm going to introduce briefly our panel. So we have Stephanie Adams in the red jacket. Stephanie holds a doctorate in pharmacy from the University of Mississippi and serves as a peer reviewer for the breast cancer research program for the Department of Defense Congressionally Directed Medical Research Program. She was also diagnosed with breast cancer at 26 years old in 2020 during the beginning of the pandemic, and has shared a lot of her journey with us at Forge. We are grateful for all that Stephanie does for us. Heather Williams in an orange. Look, we've got Auburn and Alabama represented. There you go. Boom, check. Heather is a board certified adult-gerontology and women's health nurse practitioner at the Urology Centers of Alabama. It's hard for me to say Women's Center. She obtained a Master of Science in Nursing at the University of Alabama at Birmingham and a Bachelor of Science in Nursing at Tuskegee University. Misty Smith in the, I guess that's orange as well. Look, well, you've got some red, so we'll just balance it. The LSU fan has nobody here. I'm just going to be clear. Misty has a PhD in counselor education since 2002 and is a certified sex therapist through AASECT and level 3 training for Gottman method couples therapy completed. She is a contributor for Fox 6 Good Day Alabama, Where is the Love, on the first Thursday of every month. Christina, here on the end, is a board certified women's health nurse practitioner and nurse scientist. She received her master's as a nurse practitioner and her PhD in biobehavioral nursing science from Virginia Commonwealth University and completed a fellowship in cancer symptom management research at the University of Utah. She is an assistant professor at the UAB School of Nursing, focusing on assessment and treatment of body image and sexual health issues in gynecologic cancer. So as you can see, we have quite the panel here today to answer your questions and ours. So I'm going to start it with some questions that we have already had submitted. And then in about 30 minutes or so, we'll open it up to all of you for your questions. First question, Heather, as a nurse practitioner, can you tell us the physical changes a patient might expect after a cancer diagnosis and treatment?
Absolutely. So,
you said, if you would pick up that, yeah.
yes, absolutely. So as Laura mentioned, I am a nurse practitioner and I work at a urology office. I do have a background in internal medicine as well. So I'll kind of give you a broad spectrum or a broad answer, and then I can kind of give you things specific to the urogynecological aspect of it. So I think we can all agree that regardless of what type of cancer you had, fatigue is a common, symptom that you have, correct? Because your cancer symptoms can be based on the type and also the type of treatment that you receive for your treatment. So, fatigue would be one that's just generalized. Now, if we were to do it more specifically from my point of view, we may see some vaginal dryness. We may see some urinary incontinence. You may have pain with intercourse. You may have body image concerns. Breast cancer isn't my background, but, just changes in the physical appearance of your own body. Some women have had mastectomies. So then, we're concerned about how we look with our partner.
Mm-hmm. Christina, from the way when we created this panel, kind of the way I was thinking about it is, in my mind, body image is sort of my first person, how I feel about myself. And the sex part is sort of my second person. How do I interact with somebody now that I'm in this position? So from a first person, how do I feel about my body now perspective? What kind of body image issues are common that you see in people after they have had a cancer diagnosis and treatment or treatment?
Sorry, absolutely. I completely agree. And there are the body image issues of first person or yourself, as well as what I call psychosocial or between one another. And in terms of that first person or the survivor perspective, you have both internal and external body image issues. External body image issues can be from scarring. It can be from, for example, with breast cancer, the loss of a breast or loss of hair. It can even be weight loss or weight gain or changes in that. It can be skin changes. In terms of internal body image changes, it can be related to hormone changes. It can be the loss of reproduction, the loss of fertility, and things like that.
Okay. Misty, so if we're continuing with that, so first person, then let's talk about second person. What are issues as a sex therapist that are common that you encounter with patients on what are relationship sexual issues for people after a cancer diagnosis and or treatment?
Well, I think the relational issues also come with those first person issues, because if you are concerned about how you look, what your body looks like, and you have those body image issues, then you're also going to have issues with feeling comfortable, maybe being naked with your partner again, maybe interacting sexually with your partner again. If you have erectile dysfunction, then there is the situation of, oh, I'm scared to interact with my partner because what happens if I can't perform? And then when we also have the pain issues for women, oftentimes the vaginal pelvic floor pain, then it's a real struggle to get comfortable with the idea of, okay, we're going to interact sexually, but I'm afraid. And then that translates into a disconnect from a partner, because a lot of times people just don't really understand that you can be intimate and not be sexual and not have penetration. So it's really difficult to move forward in relationships. And so people just start to drift away if they don't have that supportive partner and that encouraging medical team and therapy team to try to help them understand all of the different ways that they can be in that relationship and still be intimate and still have that connection.
Stephanie, I'm going to go to you as someone who has been, but you're wearing two hats here today, obviously. So pharmacist and survivor. I'd like to, if you're comfortable, talking a little bit about your experience and if you want, whichever part of that you want to talk about. If you feel more comfortable talking about body image issues or sex issues, whatever, but tell us a little bit from your personal perspective what your experience was.
Sure. So basically all of these issues that were brought up on the panel, obviously as a survivor, 90 to 100% of those things I've experienced, unfortunately. Body image, that being a huge thing with breast cancer specifically, and I'm sure many other cancers, your body changes completely. And especially specifically with a mastectomy, I personally had a double mastectomy that was very hard and challenging. And, you have to go through that process of grieving the loss of that and getting familiar with your new body, looking at your scars that you have that's now there. And it's just a reminder daily of, hey, I had breast cancer. And then even from the hormonal therapy side, I'm constantly thinking about from that. I eventually got really frustrated because I thought, with this hormonal therapy, it really took a lot of the aspects of even being a woman, the whole process, from the hair loss, hair thinning, the glow of your skin from the estrogen, that's not even there anymore, or the lack of sex drive, a decrease in libido, the hormone changes that all of that encompasses is very hard and very challenging. And it was for me. And so that became very frustrating. And even with the vaginal dryness or the sexual components of that, I became frustrated with my own body and just thinking, oh, it's letting me down. And that was very hard. So yeah,
Yeah.
I felt like a lot of those are very true.
Yeah. Heather, what would you suggest? One of my things that I always get frustrated about when I go to a great panel discussion is I want to walk away with some sort of action steps, right? So I want to feel empowered to what can I do? So along those lines, what are your suggestions for someone who either is in the audience or online or watches this on another day and is having some of the symptoms and issues that you described? What are your recommendations? What do they need to do from a physical, medical perspective?
From a medical standpoint, I would say, once we navigate through the initial, or once we find out we have that diagnosis, and as we navigate through it, I would recommend that at first we take the time to process it and navigate through the stages of grief. And then once we get to that final stage, which is more of the acceptance phase, then we create a plan, and as we navigate through it, we get a support group. That could be our faith community, that could be, relying on our spirituality, whatever type of cancer you may have, a support group that's specific to that. And then when it comes to speaking with your medical team, you should have a provider that you can absolutely trust, somebody that you can talk to and just tell them every single thing. If you don't feel comfortable with that provider, we need to reassess and see, what can be done so that you can have that rapport with them and you can tell them every single thing. And I would say when you go to your visits, it's important that you know your own medical history, and your family history as well. So your history, know what your norm is, so that you'll be able to identify your abnormal, your changes, and then know what your family history is. So we know that some cancers have a genetic component to it, correct? You should, I would say, write down questions that you may have. You may think of things at the house, in the shower. And then when you get to your appointment, you're like, oh my God, I can't remember what I was thinking this morning. So write those things down. I would also say maybe have one person go with you so that, you're processing a lot at that time, right? So it's nice to have that support person or that caregiver with you, excuse me, to just kind of be an additional set of ears.
Yeah. Okay. Christina, you want to follow up with that from both body image and physical and sexual? Like, what are your recommendations for someone who is struggling right now and doesn't know what to do, where to go, and how to start this process?
Sure. So my first recommendation is similar to Heather about having a provider that you're comfortable with, is broaching the conversation. So communication on body image and sexual health can be scary for both patients and clinicians. So your clinician may be just as scared to ask you as you are to ask them. So if you're willing to broach that subject and be a little vulnerable with them, hey, I really don't like the changes that I'm seeing in my body. That may open the door up just enough for us to say, okay, so tell me how you feel about that. Tell me what's going on. And then we can provide that practical advice of, okay, well, regarding this, maybe you need to see a counselor, and I've got some great recommendations for you. Or regarding that, there are actually some recommendations regarding vaginal dryness that we can provide to improve those things. So there are both over-the-counter as well as prescription medications, depending upon what's going on, that can address those issues as well. So step one is communication.
Like that. Misty, you want to follow up on that of, like, from your perspective as a therapist, what are your recommendations of how do they get the nerve and attack this issue?
Okay. Well, Christina's right. Communication to infinity, because that is the issue that I see with most people, whether we're talking about cancer-related sexual issues or not, is that you have to be able to communicate, whether it's with your partner or your medical team, or finding yourself a therapist who actually can encourage and walk you through the words to say and the time to say it with your medical team. Because as a therapist, we can only do so much. We can't prescribe medications. There are a lot of things that you can do that are over the counter, whether male or female, that can improve sexual function and get you on the right track. But well, and some of those things are really great to discuss with your partner. So if you come into therapy, you're having a hard time maybe discussing with your partner, come into therapy and we can help you discuss that together. The more comfortable you get with talking to the person that you share sexual relations with, the more comfortable you're going to be bringing that up in a medical setting. And Christine is right. Sometimes the medical professionals aren't comfortable asking you those questions. The number of times that I've had people come in and say, well, my doctor never asked me about my sex life. And so I'm like, oh, okay. I feel like that's important. And your sexual function is important. And if you have pain, if you are just feeling really fatigued and exhausted, you notice that once, but maybe before cancer, you felt like you wanted to have sex all the time. And now it is the last thing on your mind, whether male or female, then that's a problem. And you may not notice it as much of a problem as maybe your partner notices that it's a problem. And one of the things that I think is really important for individuals, couples who are going through the process of recovery and treatment is that you have to remember that, and I wrote this down so I don't forget to say it wrong, your biggest sex organ is your brain, not your genitals. And if we can get you connected to your mind and you can really be present, you have a lot more control over what's going on in the lower half of your body than you think you do. And sex is in intimacy is not just about intercourse in some way. And it may look really different than it did pre-cancer. And that's what, a therapist can help you work through. And it's also things that your medical team has to help you work through. But if they don't know what's happening, they can't assist you with that. So I would just encourage anyone going through the process to really find a good support person, a good therapist, counselor who can talk with you and walk with you through that process, because I think it's healthy.
That's great. Stephanie, as a pharmacist, are there treatments that maybe people don't know about that if their physician hasn't talked to them, which blows my mind a little bit, frankly, but I get it because they're probably focused on treating you and keeping you alive, and they're not necessarily thinking about the whole picture, which frankly is why Forge is here. But are there things that you would recommend, like talk to your doctor, specifically ask about what can I do? Are there products? Do you have some hints you can give us?
So, and I agree, it's even as a patient, it's difficult to even bring that up to your doctor. And as amazing as my oncologist was, I felt like that was maybe 5% of my appointments when I go. And so I understand she's obviously trying to keep me alive. However, I feel like from the patient perspective, that aspect of it, the interaction, the physical, for me, it's a bigger portion of the journey. And as far as over-the-counter products, I know from experience and a gynecologist telling me one of the easy and very accessible products, even to get in the store, coconut oil, things like that. And then I guess just bringing it up, I would say as a pharmacist, I sometimes found myself a bad patient. So I would just encourage everyone, if you're having those issues, do bring that up to a provider or find therapists that can help you communicate that and ask what you need. One, identify what that is, what you need, and then be able to ask for it, because why it's hard to ask, I don't know. But I would just encourage, everyone to do that, to identify what they need and definitely ask for that.
Along that same line, Heather, if someone's having pain and they come to see you, what are things that they can be done about that? What would you make? What
So-
recommendations?
So I would say that it's individualized. And oftentimes we may need to do a vaginal exam. If it's pain, it could be something internal, external, depending on the treatment that they've received. It may be something that can be fixed simply with some coconut oil, or they may need pelvic floor physical therapy. And pelvic floor physical therapy is really good. So I tell my patients, you know, we hurt our knee or we get knee surgery and then we go to physical therapy, right? Well, same thing. If we've had something traumatic happen to our pelvic floor, then we should still go to a physical therapist who can help us with that. So I really advocate for the implementation of that as well, because that's beneficial. And I've seen it be beneficial in my patient population. CO2 laser therapy. So that is when a probe is inserted into the vaginal canal and there are small microscopic abrasions created. And the way that that works is it helps to replenish new vaginal tissue growth. So Christina and I were talking earlier about like natural changes with menopause, cancer treatment, and we talked about, okay, if this is how thick our vaginal lining is prior to menopause, prior to cancer treatment, when everything is perfect on a good day, you know, with changes, traumatic events, cancer treatments, our vaginal lining, it thins, right? So when that probe helps to create that rejuvenation, it helps to thicken it back up. Now, no, we may not get to how we were in 9th, 10th grade, but you know, the goal is to improve the tissues from that standpoint. Medications may be implemented, you know, if there's a psychological component to it that's causing depression, anxiety, maybe the medication could be contributing to that sexual function as well. So then we may need to change our medication. So that's why I said initially it's an individualized care plan. So there's no one, you know, algorithm or protocol for everyone. We're all different people, right? So we all require different treatments.
That's great. Christina, I'm curious, one of the things that we hear at Forge a lot from our clients is that, you know, they feel terrible on their hormonal medicine and they hate it and they want to go off of it and sometimes just unilaterally decide I'm done. What would you say to someone that they feel like that's a big issue? What should they do? And I'm going to assume you're going to say, don't stop cold turkey, which is what we say too, but what would your advice be for that?
It's ironic that you bring this up because I've had this conversation with multiple patients in my clinic. They're like, this is causing the problem, so let's just stop it. And I'm like, no, then we're going to create another problem of your cancer coming back. And then you're going to have to go through all those steps that you went through that caused the problem, that caused this problem in the first place. You're going to go through those and it's going to cause it even and make it even worse potentially. So step one, no, don't stop your hormonal therapy. 2, let's talk about the symptoms and the side effects of your hormonal therapy. What are the ones that are bothering you? Is it the fatigue? Is it the vaginal dryness? Is it the hot flashes? There are multiple hormonal therapies depending upon the type of breast cancer you have. And potentially talking to your oncologist about switching hormonal therapies could be an option, or we can manage those side effects of the hormonal therapy you're on. So there are ways to combat hot flashes, vaginal dryness, fatigue, both pharmacologic and non-pharmacologically. And similar to what Heather said, this is an individualized approach too. So there are some things that may help you that may not help someone else, depending upon the medicine and how you're responding to the medicine.
Okay. Misty, I want to ask you, so I know in the perfect world, someone will go out and book an appointment with a therapist to talk about it, right? But we also know that in reality, there's still sort of a stigma around for some people going to get counseling and therapy. So let's say somebody's not ready yet to take that step, but they're struggling with this at home. Are there some things they can do within their relationship at home to try to start having this conversation and get to, try to create a solution on their own before they go for professional help? Does that make sense? I know that's not great, but like there are going to be people who are like,
Yes.
I'm not going to go get mental health care. They just aren't. And we encourage it as much as we can at Forge. But for someone who isn't, are there some things they can start doing at home to try to make it better with their relationship with their partner?
Sure. So if they're unwilling to come to therapy, which I really think that the stigma is changing a bit with therapy, and almost everybody is at least, or most people are at least proponents of it, whether they choose to go get it or not, is that we go back to the communication. I think the internet is just such an amazing resource, because if you don't know the questions to ask, the ways to start those conversations, you can really merely Google conversations to discuss with my partner around sexual issues with cancer. I mean, and you're going to get pages upon pages of information that is going to help you start those conversations, and really exploring what and sometimes people just don't know this prior to going to therapy unless they are doing a lot of reading, is exploring how to be intimate without the intercourse piece of it, really trying to understand how to accept and love and appreciate each other's bodies without, and verbalizing those things without it turning into something that is expected to be sexual. So again, we go back to just communication, because if you're not communicating with your partner, if you're not, really talking about what's going on for you, what's going on for them, and if you are a partner, using, again, if you're unwilling to go to therapy or you just don't think about it, that you Google resources and ways to help your partner through it. And you're going to come up with a ton of resources and conversation starters that will at least get you moving in the right direction. And then if you feel like you stall out or your partner's unwilling, then those are the times where you say, okay, it's like going to the gym. If you go to the gym and you don't see results, guess what? You probably need to inquire with the trainer. And this is the same thing. If you're trying it at home and it's just not working, whether you're the patient or whether you're the partner, then it might be time to consider bringing in someone else. And fortunately, in my world, I love what I do because I get to be the investigator, and I get to spend the time that couples need or individuals need with them, specifically talking about the thing and exploring and pushing those conversation boundaries a little bit and getting people to talk, because people will come in and say, "Ooh, is it okay if I talk to you about this, about my erectile dysfunction or about my pelvic pain?" And I have to remind them, I'm a sex therapist. Yes, it is. That is what I listen to all day, every day. So, but really, especially here in this region of the country, we are not taught to freely speak about our sexual function and our sexual relationships. And finding a therapist who is open to talking about that, because even though that is my specialty, there are other therapists out there who are really open to talking about what your sex life looks like. So if it's not working at home, if you've tried all of those conversations and you're still not moving in the right direction, going in for your own therapy session, regardless of partner, patient, and talking to a therapist about how to get your partner to join you is a really great step.
I'm going to stick with you for a second. What about the other piece? What if I don't feel good about myself and I'm having self-esteem issues? What are some suggestions that you have are there things people can do at home to learn to be comfortable with their bodies in this new state?
Yes. So, all right. So making sure that you are picking out those things that you do love about your body, that you appreciate about your body, learning to see beauty in your body, regardless of what it looks like now. I mean, I am in my 40s now, and things don't look the same that they did when I was in my 20s. So I have to get comfortable with that, whether it's aging, whether it's cancer. My aunt actually started her cancer process and a double mastectomy at the beginning of COVID as well. And she and I are really close, and she has, she takes her shirt off and walks around the house, and she has really embraced, like, what do I still love about my body? What are those positive things? And I think that some of that, just connecting with yourself, being willing to stand there and appreciate life, and having a partner who can do that with you, I think is really important. But you have to express to your partner that you need that, because if you can't express to your partner, hey, I'm struggling. So after I had children and I lost some weight, I nursed and I felt super uncomfortable with my body. I had to express that to my husband. I had to let him know that this was a problem for me. And otherwise I didn't have his support. I did it all on my own. It was all internal. And that's not a healthy place to be when you don't feel good about things that are going on. So being comfortable enough to just say, I need your help, is one of the first things that I think we do, because sometimes just doing it on your own is not enough. So whether that is a partner, or whether that is your best friend, whether that is your mother, your sister, whoever it is, you find that person who's going to be able to stand there with you and look in the mirror and help you see all of the things that are still beautiful about you.
Stephanie, will you tell us a little bit about yourself, things that you did to make yourself feel better, or do you have some words of wisdom for us of what you've been through?
Yeah, absolutely. So as y'all know and have heard, there's just a ton of things that changes about ourselves physically and mentally when going through cancer. And I think one of the biggest things that you can do is really just, looking at all these different things, assess and determine which things that you actually can change, and find those things and do what you can do. Some of those small things were before treatment, I felt like I had to do every little thing that I possibly could to help prepare myself to be as normal as I could during this process. And that was making sure that I got eyebrow gel and cream and doing cold cap therapy to keep my hair, getting good moisturizing cream for my skin, making sure that I had all the makeup that I wanted so that I can still feel normal when I go to work. And it was just trying to find all those things that I could control, because I knew I couldn't control all of them. And I had to accept that. And I would encourage, everyone else to do the same, because you won't be able to control everything. And then just in those things that you aren't able to control or change, give yourself grace in that area, and give your body some credit, because it has been through a lot and will probably continue to go through more. But giving yourself that grace and space in that area is good too. And then additionally, into something that you can do and something I have found beneficial is just adding on to what's been said on the panel already. And that's communicating. I'm very fortunate to have a wonderful husband who's also a Forge volunteer. And something that I've learned, and I'm grateful that I've learned in adulthood, is communicating and realizing and figuring out what I need, and us doing that together. And that's very huge and very important. And if that's not a spouse, communicating with your best friend, like that was mentioned, it's very important, not only physically for the things that the things you're going through with those physical changes in your body, but mentally as well. That's going to help you just get through something very difficult.
I'm going to open it up to questions from the audience. Is there anybody who wants to ask a question? Yes, Dr. Carpenter. Okay. Sure. Yeah. Okay.
Oh, here we go.
Yeah, there you go.
I'm John Carpenter. I spent 40 years at UAB, the majority of them taking care of people with breast cancer. And I have talked about this topic with thousands of women. And if you listen, people tell you a lot. You'll already know that. And finding somebody to listen to you can be an issue, as you all know. The sex is a remarkably normal part of life, and it's disappointing that it's so hard for many of us to talk about it. It's important before you have a problem like this. It's just as important afterwards. And it's part of the normal life. And so if you want to get over your disease and get your life back to normal, this is an important component of that. People should be encouraged to maintain that and to maintain their relationship while they're getting all this treatment, because the purpose of all that treatment and all that junk is to get your life back. Getting your sexuality back for most people is part of that. So it's so normal. Everybody has body image issues, usually before and frequently a few more afterwards. One of the things that can be done that's simple, darkness can help. Okay, I'm serious. I'm serious because it takes the focus away from that. And it makes people a little bit self-conscious, and it doesn't cost very much, and it's simple. It does. It does. For most breast cancers, all the ones with hormone receptors, there are the basic treatment, the most important thing is to take away the estrogen. There are two basic types of drugs. There are ones, tamoxifen is the example, that interfere with estrogen action. These drugs thin the vaginal mucosa and they oppose estrogen effect, but they in fact are just a different kind of estrogen. So it's a funny difference. For women past menopause, the basic thing is to stop the residual estrogen production. And aromatase inhibitors, there's a whole string of them, 3 or 4 of those, and they basically stop estrogen production. So you get more severe side effects. Fatigue is common. Hot flushing can be trivial or severe. Everybody gets a sandpaper vagina, which for most people is pretty uncomfortable. Not just physically, but importantly, very emotionally. I've got I have a request to write up my experience, but what I did and what is proposed, but frequently not done, is to use vaginal estrogens because they replenish the vagina. It's all the official recommendations say to do it, and the doctors in general don't. You should realize that we don't know how much deprivation we get when we give the same pill to everybody. We don't know if it's the same for every tumor or not, and we don't know how to individualize. So we all deal in a bunch of, this is what we do, but this is what we do for the population, but we don't have a clue what to do for the individual person. Tiny bit of vaginal estrogen, a drop on the end of your finger, used daily for 2 or 3 weeks will totally revolutionize. It'll make the vagina like it was when you're 30, okay? And if you're not 30 yet, it's not so different from when you were 25, from what I'm told. And I don't know about all this except from what people have told me. But there's no evidence that you absorb an appreciable amount of that. Even if you did, and you take a drug that interferes with estrogen, if you absorb some of that, it gets blocked anyway, so it's trivial. So for people who take tamoxifen and stuff like that, a little bit of that will fix their problem. For the women who take the estrogen deprivation drugs, they probably don't absorb enough to matter. all the recommendations are to do it. Interestingly, it's a common problem outside of breast cancer. In the United Kingdom, they're thinking about making an over-the-counter pill available that's a tiny amount of estradiol for women to get to that part of their lives. And they want to make it over the counter because it's harmless. The Oxford people, the best epidemiological group in the world, studied this, and in the Lancet in 2019 published a paper that they couldn't find any problems.
Good.
They couldn't find it. So safety's
Goes back to communicate, talk to your doctor, tell them it's a problem. And if they aren't listening, then go find someone else who will.
but
Yeah.
it should be just an absolutely basic, normal thing.
Okay.
Um,
Thank you. How
Two
much
quick
more do we
things,
have here, Dr. Carpenter?
not much.
Okay.
The evidence base that the best thing for fatigue is exercise.
Okay.
Start slow, but all the studies look for that and they show that. And the thing people do that screws their skin up is to put soap all over it. You only need soap under your arms and on your bottom. Your body doesn't generate odor anywhere else, and it dries your skin. So if you talk to women about taking care of their skin when it's drier, first thing is leave all that soap off. If you need to, use one of these things that makes it more moist, and you'll be a happier camper.
Always helpful to us. You really are. Thank you, Dr. Carpenter. You are a gem. We appreciate that. Did I see? No, I thought you had a hand raised. Yeah. Versus. Right. And some of it. Yeah. And I'm going to repeat a shortened version of it for those of you online, in case you didn't hear. But how do you know if the symptoms and issues and concerns that you have are cancer related or just aging related and part of life? Is that a fair?
I think very true, actually.
Yeah.
I think that if you're in your 20s, you probably know what is supposed to be normal for your age versus this is cancer. If you are 35 and above, a lot of times women experience dryness and it feels very abnormal, and it's usually hormonal. If and I don't know the testosterone with females and cancer and things of that nature, but when our testosterone levels oftentimes start decreasing when we're in our 30s. And if we have ever been on oral contraceptives, then there are things that are affected that impact testosterone levels. Women to have that just more natural sensation and libido, oftentimes that is part of it. I do like what he had said just in regards to moisturizing vaginal tissue, because if you take care of your vaginal tissue, even if your hormones are a little off in terms of testosterone, you still might create some additional sensation. But I think it is difficult to know when you're in your 60s, what is just due to aging and what is due to cancer, because women some women in their 50s and 60s have higher sex drives than I've ever had. And, and sometimes in our 30s, sometimes women go, I could never have sex and be completely fine. When people come into my office, we explore all of the options that are available in terms of just making sure that you are taking supplements that are available and making sure that vitamin levels and blood work and hormones are where they should be. And when we're talking about dealing with cancer, there are things we have to work with that are a little bit different than just when you're not. So I would say if you aren't happy with where your libido is and or your partner's not happy with where your libido is, then it doesn't really matter if it's cancer related or if it's age related. Talking to a professional, exploring the options is the best idea, because I have seen 70 and 80-year-old women and men in my office, and I will repeat, women who are still as interested in sex as they ever have been, and possibly more. So it is, if you want to continue to have that part of a relationship, then there are options that can absolutely increase sensation. And that's the big part, is if you don't have sensation in any erogenous zones of your body, it's hard to trigger your brain to go, oh, I want to have sex. So if you walk around not necessarily even recognizing that any genitals attached to your body are actually meant for sex, then you're going to have a problem when it comes to you going, oh, okay, I should want to have sex, but I don't feel it. Or your partner is saying, hey, I want to be intimate with you, but they touch you and you are wondering when they're going to finish so you can watch the next TV show. So I've had couples who are completely content with sex twice a year. And if both of them are happy with that, then that's not really a problem. If they're not happy with that, is when we start exploring all of the options.
Heather, I feel like you had something you wanted to add.
Yeah, so I agree completely with what Misty mentioned. So when we start talking hypoactive sexual desire disorder, one of the key components to actually making that diagnosis is when it becomes distressing. The word distressing is specifically in that diagnosis, when it becomes distressing to the woman. So when it becomes a problem for you. So if your partner is distressed by your situation, but you're completely fine, that's not hypoactive sexual desire disorder, or it's not really problematic. It's dependent upon you. Now, granted, as Misty mentioned, we do have those natural changes with the estrogen and the testosterone levels throughout the body. But again, the bottom line is when it becomes distressing specifically for the woman, that is when it should be addressed. I agree completely, Misty.
You want to add? Yep.
Yeah, exactly. And just because you don't have spontaneous desire does not mean that you have hyposexual desire. It is very, very common that especially women have what we call responsive desire. And studies show about 80% of the time, women have responsive desire versus spontaneous desire. Spontaneous is out of the blue, I want to have sex. Responsive is my partner touches me. I see my partner doing something that really helps me, cleaning the house perhaps, all sorts of things.
Snapping in the back.
So I just wanted to clarify that, yes, it has to be distressing, and just because it doesn't come out of the blue doesn't make it a problem either.
Daphne. Yeah.
Feel comfortable enough. It's difficult.
So I'm going to rephrase it briefly, and I'm not going to do nearly the job you did, but how do you start a new relationship with someone post breast cancer or any cancer treatment, and have those conversations with someone that like, hey, nice to meet you. By the way, we're going to need to have a talk, right? Like, how do you approach that?
You know, and
but it's a good one.
So I'll start with this one. If and I approach these conversations just like the ones with individuals who come in who have acquired an STD that is going to stick around for a lifetime. I think it makes us much more aware of the people that we're dating. It makes us vet them much more carefully. And when I don't think those are conversations that you need to have in the first date or the second date. I think that those are conversations that you have once you have established some sort of connection, and which is also why I encourage people when you're dating, make sure that you are asking all of those questions. I tell people when, after divorce, when I would meet someone, they got an Enneagram assessment, they got a Myers-Briggs assessment, they got a love language assessment. And now if I stop dating my boyfriend and start dating, they will also get an erotic blueprint assessment, which I will go back to on something Christina said, is that if they meet all of those things and they look like a potentially great partner, then I'm going to share this thing with you that's really personal for me, because I trust you enough to think that when I share that with you, you are going to not run screaming, and you are going to at least consider. I mean, my ex-husband had been married twice and had 2 kids. When he sat me down to give me that information, he goes, I know you're going to need time to think about it. And I was like, yeah, you're right. I do. I didn't run screaming. I took a few days. But then I thought, he's worth it, right? And if you've spent enough time with somebody for them to know you're worth it, then I think it's time that you can share that information. And if they choose not to be in that, remember that sometimes it has nothing to do with you having 1 boob or 2 boobs or no boobs. And it might have nothing to do with a man not being able to get an erection. It might have more to do with that person isn't up for the hard work that relationship's going to take, and you want to get them on out the door pretty quickly.
Yes, in the back. All right, let me repeat, or you want to repeat the question for me? Because I'm not going to mess that up. You use words I
mess
don't.
it up either.
All right. It's called CO2?
Yes,
CO2 therapy. Can you tell us a little more about it? And is it covered by insurance?
No, it's not covered by insurance. I know, but it's really good. I assume that insurance would consider it cosmetic per se. But it's really good at replenishing the vaginal health and the vaginal lining. Yes, yes. Yes.
Yes, in the yellow. Oh, how much does it cost?
I'm not sure.
Okay.
What I would recommend is we do it at our office at the Urology Centers of Alabama at our Women's Center. So if you contact our office there, got an ink pen? Okay, 205-795-0084, and they can give you additional information at that time.
Yes, ma'am. Okay. Yes. That's a great way to ask that. Yeah, so the question is, if you're HER2 positive and you have libido issues and other issues on top of that, are there things that you can do about it? And you would, Christina?
Absolutely. So first, I'm gonna take it back to, it's an individualized approach, and you need to have a complete assessment of what's going on from both perspectives. Also, more things than just can contribute to your libido. I often see patients who come in after having breast cancer diagnosis saying, I have low libido. And I do an exam and they have severe vaginal dryness. Well, if you have severe vaginal dryness and you even attempt to try to have sex or want to even have desire, and it starts causing pain when you try to get aroused, it's going to send a signal back to your brain. As Misty said, the biggest organ is your brain. It may not trigger desire. And so it's hard to say yes or no in terms of just desire if you don't know if there's vaginal health issues, if there's other things. But yes, there are things that can treat desire itself if that is a standalone issue.
Yeah, the responsive, yeah. Okay, some of your comments may be my favorite comments of the day. I love it.
So
Yeah. Yeah.
Okay, so that last statement, very important. He comes to you late at night. One of the things that everybody who is dealing with cancer or not, but specifically, is to make sure that you are letting your partner know when you have the most energy, because you're going to feel fatigue. You're going to feel that, I just want to sleep right now. And most of the time at 10 and 11 o'clock at night, I tell people I don't understand why people think that sex only has to occur in bed at 11 o'clock at night. So it can occur at all times of the day. Actually, I would say that most people seem to have a higher libido and more energy and excitement about sex between 12 and 5. So if that's when you are feeling the most energized, and most women do have that responsive desire, then also, I'm not really a big initiator, let your cute little bald-headed husband know that he is going to really have to take on that role of initiating, because one of the questions I ask, and I'll be gender specific on this, is when I ask a woman, do you enjoy sex once you get started? Do you have an orgasm once you start having sex and you get to that point? Yeah. Okay. Then chances are you're having a whole lot more of the responsive sexual desire happening. And if that's the case, your partner is going to need to understand that you not taking the initiative isn't that you're not interested in sex. It's just that's like, you can say, okay, it's 1 o'clock and I'm not really interested in sex, but hey, I've got a lot of energy. Let's do it. And that may be a role that you choose to play occasionally if you feel more energetic. I don't know if your man works, but maybe giving him a call for a lunchtime visit home might be arranged. But if you can pay attention to your own body and really verbalize that to him, it might be helpful going forward. And also, I'm going to go back to the thing that I was going to go back to earlier, is when I said erotic blueprints. So how many of you have heard of the love languages assessment, right? Pretty much everybody. So there are 5 of those. And I've always had kind of an issue with bringing like love languages and sex together exactly, because if you're an acts of service person and your partner is a physical touch person, AKA maybe that equals sex, is that how many acts of service do they have to do before you're willing to have sex with them once? So there is this nice little erotic blueprint assessment out there, and it's at Miss Jaya, MISSJAIYA.com, and it costs like $17 to take. Totally worth it in my opinion. But it gives you basically your 5, I refer to it as the sex languages, and it kind of helps you understand what turns you on, what gets you excited. And it's probably not always them doing the laundry, because people have sex with strangers all the time and they have great sex. People can have makeup sex and it's great sex. Like what is the thing that your partner can pay attention to and know to do that might get you moving towards being in the mood? Foreplay doesn't have to start in the bedroom. Foreplay can be, rubbing your feet or feeding you a great dinner. And if you know that and you know your partner's kind of sexual language, then it's going to be a lot easier for him or her to pay attention to that and really direct their energy that way versus just, I'm doing all of these chores around the house, or I brought you your favorite snack, but you're still not in the mood. Okay.
I love it. Yep. I think we're gonna have one more. You good? Yeah.
So it's variable. Just because it happened to her doesn't mean it's going to happen to you. And just because, and I'm sorry, I know it sounds awful. But it could be other contributing factors. It could be coming off tamoxifen, or it could have been other things that are happening around the same time you were coming off tamoxifen that have led to it. It could also be a shift in your system related to coming off of it. And then perhaps, I don't know how long you've been off of it, but after you've come off of it for a while, sometimes things can pick back up. So it is a individualized type thing, and it doesn't necessarily mean that just because one person has that change, it doesn't mean that it is going to happen to someone else.
All right. I want to thank you all. This has been really great. I appreciate it. Personally, I'm telling everybody we're going to go take our erotic blueprint. I want to hear from everybody what your results are. But no, this is great. Thank you. Thank all of you. And we will hopefully see you next week for our final Candid Cancer conversation, which is end of life palliative care decisions, how to be prepared before you need to be prepared, and decisions that you need to make. So hopefully we'll see you next week. Thank you.